Good afternoon, everyone, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, Marketing Specialist, and I will be your moderator. Today, we welcome Dr. Dan Butterman as our speaker, as he will discuss the fully digital implant workflow with Dentsply Sirona's Axeos 3D imaging system. Dr. Butterman is a fellow of the International Congress of Oral Implantologists and is also a resident faculty at cdocs.com. Before we get started, we have a few reminders for you. At any point during the webinar, if you have a question, please type it into the Q&A section of your control panel and we'll answer live at the end. Henry Schein is not offering CE credit for viewing or attending this presentation live or on demand. And this webinar is sponsored by Dentsply Sirona. Dr. Butterman, thanks for being with us.
Thank you. Thank you. Let me move myself out of the way here a little bit so you guys can see the slides. Well, thanks everybody for being here. I know it's probably been a long day for most of us, myself included, but I'm really excited to talk to you guys. This is really one of my favorite topics to discuss. Just a couple things logistically, and I'll just kind of talk a little bit more about myself just so you know who is speaking to you about this. But logistically, we have a Q&A section, we have a chat section. We can certainly, I'm going to definitely leave some time at the end for questions, but if there's stuff that we want to kind of get out there, absolutely feel free to type into the chat or use the Q&A, and I'll try and keep an eye on that, or Adam will keep an eye on that, and we can talk about those as they come up. Just a little bit about me. I practice in Denver, Colorado. I have a full-time dental practice. Well, full-time for me is about 3.5 days a week. That's my first full-time job. My second full-time job is that I speak for CEDOCS. I'm resident faculty for them, and I do a fundamentals CEREC course, and I also teach an implants in the aesthetic zone course for them as well. I did my implant training with Carl Misch many years ago, and I just realized because of Facebook, probably like a lot of you, this is my anniversary of graduating from dental school. And it's 28 years today. So I know a lot of you are thinking there's no way he could possibly be that old, but yes, actually I am. And then the last thing that I spent a lot of time doing is beta testing. And I beta test for Dentsply Sirona and a lot of the hardware, software, material side of things. So I have a very deep understanding of not just what's on the market, but what it's going to look like a year or 2 years down the road. And I really have a firm understanding of what the direction things are going to go in. So certainly I can hopefully guide you a little bit with that. It's actually, if any of you have ever beta tested, it's like the worst job in the world because you're kind of guaranteed to just every day have problems. But that's kind of the point of it. So in my 28 years of practicing dentistry and my many more years than that outside of dentistry, I've noticed that a lot of things have started to become obsolete. And technology is sort of one of those things where it's really interesting because you always try and decide, do I want to jump in now or do I want to jump in later? What's the right time for this? And it's such a moving target and things are always changing that you don't necessarily want to be the first one on the bleeding edge like me, because then you have to deal with the problems. And you don't want to be the last one either, because then you're sort of getting left behind. And I would argue that this has become obsolete. I certainly started using film in my practice many years ago. Well, not many years ago, 28 years ago. And now I know it's still in use in some areas, but I think that's really becoming the norm that we're just not using film anymore. One of the things that I have noticed a big change with is the fact that the redefinition of what a full series of x-rays is. When a patient comes in and they maybe transfer from another office and they bring me something like this, I quite honestly struggle with it because I'm just not used to looking at 2D images anymore because we just don't have anywhere near the level of information that we can possibly attain. And arguably, we're exposing our patients to much more radiation on these full series of x-rays with 18 and sometimes 20 individual films. So when a patient comes into my office, this is what they are greeted to. A full series of x-rays for me is going to be a full arch scan, depending on the field of view might be much smaller than this, depending on what we're trying to see and what we're trying to evaluate. But this is the largest field of view with the Axeos. This is a 17 by 13 field of view. When they walk into the treatment room after their scan, this is what they see up on the screen. And I can tell you If you put an image like that on the screen, they are unimpressed. Walking into this, they've never seen that before. It's just such a different experience that your patient starts with. And right away, it just sort of gives you instant credibility because they're just blown away by the technology side of it. If you haven't seen it, and I'm not going to spend a ton of time talking about Axeos, I just want to mention it because this is what we're typically using day to day in my workflow. But really, for me, it's about the workflow, and that's what we're going to spend the bulk of this webinar discussing: is being able to predictably do guided implant surgery. But the machine is just super straightforward. It's real techy and it looks cool. And really, as far as my team is concerned, whether they're doing a larger field of view, a smaller field of view, a high definition film, or a lower resolution, it's just super easy to get what they like. Doing a high definition scan is very, very simple, and it's very quick. If you haven't done it, the automatic positioning makes this easier than a Panorex to take, whether it's digital or film. There's just nothing really, there's really no learning curve with this. And as far as the patients are concerned, it's such a quick scan. This is the highest field of view, highest definition scan, and that's the entire length of time for the scan. So they really don't have to hold still. And that's important because some of the other scanners out there, the patient has to hold still for quite a long period of time, and that can lead to poor images because of movement. So generally in my practice, depending on what I'm going to do, I'm going to choose the field of view and the resolution I need. So for example, when a patient has a root canal done, or I've treated a root canal, or I've placed an implant, I no longer like to evaluate that with just a 2D film. I'm going to take a small field of view and I'm going to do a real low resolution scan or a low definition scan. And that's going to be something that allows me to see the result at basically the same radiation as a 2D film, but I can see it in 3 dimensions. Now, if somebody's coming in, we're evaluating sinuses, we're evaluating TMJ, then we sort of move up that scale depending on what I'm looking for. So let's jump into the implant side. As Carl Misch used to say, nobody wants implants, they want teeth. And we sometimes forget that. We sometimes focus on the implant first, and we put the implant in the right position. But then when it comes to putting the tooth in or the restoration for the patient, then we get stuck. And now we're dealing with a lab that's kind of reaching out and saying, hey, you know, well, we've got to compromise with this case. So in my opinion, we really need to focus on the restoration, and then the implant is going to follow. And that's typically how I'm going to do it in my practice. Now, if we focus on the implant here and we disregard the restoration, that's when we sort of run into trouble. So when we're evaluating space for a patient, we have to look at a lot of different things. And the first one is, how much room do we actually need, and how do we evaluate that? Because not everybody's going to bite down like this guy, and it'll be immediately clear that there's not enough room for it. So when I evaluate, I'm using 2 main pieces of technology. I'm going to be using my Axeos scanner for my imaging, so I can see a 3-dimensional X-ray view. And then I'm using my CEREC prime scan for all of my optical imaging. And the 2 of those merging together is what's going to basically allow me to do all of this. So let's look at a typical case. If a patient comes in and they're just missing maybe tooth number 19, and we want to make a decision, does this patient have enough room? Well, how much room do we even need to begin with? And quite honestly, if you have about 7 millimeters from the platform of your implant up to the antagonist or the opposing tooth, you're going to be able to do really any type of a restoration with that. Mesial distal, sorry, I'm in the way here. Mesial distal, if we have about 7 millimeters of room, again, we're going to be able to recreate a proper restoration. And that 7 millimeters comes in that we want to leave the implant approximately 1.5 millimeters away from the adjacent roots. And then on average, we've got an implant that's somewhere around 4 millimeters wide. So that would total up to about 7 millimeters in order to accomplish that. Let me mention how I do a prosthetically driven plan in my office. And I just want to show you based on an example that happened not too long ago. This patient came into my practice, and his wife was a patient for many years, and he was congenitally missing a canine, and he finally lost that the primary canine that was there. And he's like, well, I need a tooth. And so he was scheduled with a surgeon in town to have an implant placed at number 11. So his wife convinced him to come at least get a second opinion by me. So I did what I always do in my practice. My assistant pulled out my prime scan, and all she did was did an optical scan, and she drew a margin around where tooth number 11 was supposed to be. So the software is able to give us a crown proposal. And now we can have a conversation with the patient. We can say, hey, this is what your crown is going to look like. Are you cool with that? Is that fine? Here's what we can potentially do. Now we still need to look at bone, but this is what your crown should look like. And when my assistant did that, she put the lower jaw into place and saw this. Now we obviously don't have enough room. The patient's occlusion is in the way. So I think we've all had discussions with patients, whether it's because of implant or maybe aesthetic treatment that we want to do for them. And we say, hey, you would be so much better served if you would do ortho first. If you would just move the teeth in the right space, then we'd get a better result. And what do our patients always say? They always say, no, there's no way I want to go into braces. But you show them something like this, and then I can show them, well, that's what your final crown is going to look like. You're going to spend a lot of money for an implant and a crown. And if you're cool with it looking like that, I'm all good, let's go. And most of the time they're going to say, well, no, that doesn't look very nice at all. Because you're looking at what the final result is. And then I get to say, well, it's your choice. It's either that or you're going to move your teeth out of the way and we can have a proper looking tooth. So that's a much easier conversation. And this patient did ultimately go into orthodontic treatment so that we could get a good result for this case. Sometimes the crown can be placed in the right spot, but we don't have the bone in the right spot. And if we're not doing a 3D image, and quite honestly, when it comes to imaging for implants, I know legally, and I do a lot of legal defense stuff for dentists, I know legally a 3D image is not necessarily the standard of care. It's not required to do that. But I got to say, planning an implant based off of a 2D image, man, you are putting yourself out there because it's just becoming the normal. And I promise you, when somebody like me, an expert witness, or somebody else comes along, the very first thing they're going to do is get a cone beam scan, and just because we can see everything with it. So if we look at this case, and we say, hey, we want to put an implant in that premolar position, and we've got a good volume, we've got a good window of bone, a lot of us may say, well, let's just center it in the bone, and that'll be great, and we'll have a well-placed implant. And if we ignore where the restoration is going to go, then we're going to have problems. That crown that we designed needs to go here. This is where it belongs. This is where it fits into the occlusion because I planned it in my CEREC as a final restoration. This is where it's going to sit in the software. So if we have the implant planned like this, we're going to have a problem. This is going to be that case where the implant goes in and then you send the case to the lab and the lab is like, yeah, I don't know. These are the cases that you lose sleep over simply because we didn't appreciate where that final crown was going to go. So what if we angled the implant? What if we moved it and positioned it in bone? And that might look strange the way it's positioned in bone. But if we want to do a screw retain restoration, then that's where it's supposed to go. And if we don't look at that crown position first, honestly, we just wouldn't know that. So something like this is going to be easy to restore. That's something I can do a screw retain restoration if I want, and we're not going to have issues with that, even though it looks funky on the x-ray the way it's positioned in bone. Alternatively, centered in mode, we'd be stuck. So we do want to make sure that we're really evaluating all of these things. I do this in front of my patient, and you'll see in a minute how I plan. I do this in front of my patient before surgery. So what are the advantages of a digital workflow? And really, the biggest advantage for me is that it's going to be predictable. I'm going to understand where my final restoration is going to be before I ever touch the patient. The patient's going to have an understanding of what compromises we have to make, or what compromises we'll need to make because of their biology. And we all know the saying, anything that you tell a patient after the procedure is an excuse. Anything that you talk to them about before the procedure is an explanation. And so I like to explain things to my patients. I don't like to dance around and make excuses afterwards when things don't go right. So it's about safety as well, right? This doesn't happen just to bad surgeons. These sort of things happen every day. And it's just sometimes the implant just gets away from you. You lose perception. If you're freehanding an implant, we can end up with disastrous results like this. Have you ever noticed that an implant placed in exactly the wrong spot will integrate 100% of the time? It'll be like the healthiest, most solid implant ever. These have become nightmares to try and restore this kind of stuff. So why does this kind of stuff happen? And it's either because we didn't have a plan and we didn't know where that implant should go, or we didn't have an easy way to execute that plan. And during surgery, things got off. So we need to have both of those pieces. We need to understand the plan and we need to understand the way to execute that plan so that we don't end up in these situations. When I talk about implant restoration to dentists and I ask the room, I say, well, how many of you would like to do, is your preference to do a screw retained restoration? The vast majority of the room will say, yeah, for a molar especially, I want to do a screw retained restoration. Well, if you've ever done a screw retained restoration or you do multiple restorations, you're going to once in a while get a restoration back from the lab, or you'll make it yourself, and you go to place that restoration in and you try and seat it and it doesn't go down. And so what do? You say, well, it's probably a tight contact. So you take a little bit away from the contact and then you try and get it to go down again. And then it just seats a little bit more. And you're like, okay, well, I'm on the right path. So you take even a little bit more away. And then all of a sudden the crown drops into place. And what do you have? You got an open contact. And that's really a struggle to deal with that situation. So why does it happen? It's because we've got an index. Screw retained restorations are not as easy to place in. I know a lot of you don't like to do cemented restoration, but screw retained restorations, you've got two different paths of insertion. You've got a path of insertion of the indexing that has to fit into the implant. And then you have a second path of insertion for the contacts against the adjacent teeth. So if your implant isn't parallel with the contacts of the adjacent teeth, it's not going down. That's when you're going to struggle. So if you want your restoration to be screw retained, rather than trying to parallel your implant with the roots of the adjacent teeth, just get it parallel with the contacts of the adjacent teeth. And it's going to be much easier to seat and place those in. Let's talk about time involved, because our patients, especially in the age of digital and CAD/CAM dentistry, our patients are expecting things very quickly now, and it's not okay for things to take weeks or months. So what's the typical workflow when somebody's missing a couple teeth? What do most of our colleagues on the analog side do? And really the big thing that you'll notice is that it comes down to timing with this. So for example, patient's missing a couple teeth. So what do? Well, you take an impression, because that's what you always do when you're not sure what to do. After you take an impression, maybe you're going to say, well, let's send this to the lab and we'll have the lab do some sort of a diagnostic wax up. Okay, so now we know where the teeth are supposed to go. And then that's probably going to take a week or two before they get that back to us. And then you might say, okay, well, we need to take an x-ray and we need to be able to see where those teeth are in relation to the bone. So then you might ask them to make a barium sulfate scanning guide. So another couple weeks, another couple $100 for them to do that. And then after that's ready, maybe you'll then send your patient off and we'll have an x-ray taken. Sorry, I'm in the way. We'll have an x-ray taken, and then you've got something that has the barium sulfate on the x-ray, and now you can appreciate it. And then so now you're going to tell the lab, okay, now make a surgical guide, and now you're in it for another couple weeks and another couple $100. So by the time the patient says, hey, I'm interested in placing a couple teeth and doing some implants, it's been quite a while, and you've spent already, or the patient has spent already, a lot of money just to do the planning. So let me tell you how I do it in my office, because it's a little bit different than that. If I have a patient that comes in and they're missing a molar, for example, I'm going to say, okay, well, let's talk about how we can potentially restore that. So the first thing I'm going to do is take an Axeos scan. And that's going to be the first thing, so that I understand the biology. What are we dealing with? What are we dealing with in 3 dimensions, so that there are no surprises? Then my assistant is going to pull out my prime scan, and we're just going to do an optical scan and try and capture that area where it's edentulous. The software is now going to give us a crown proposal. Now that is the actual crown proposal, meaning that if the upper tooth, maybe the patient had been missing this for a while, and the upper tooth had super erupted into that spot, well, we'd know it immediately, because the proposal would be really, really short. And that would be an opportunity before we do surgery to have a conversation. We can tell the patient, hey, look, this is what your crown's going to look like. It's really short because your upper tooth is in the way. What do you want to do? And we get to kind of do those sort of conversations. Once we're happy with the crown design, then I, in front of the patient, import it into their x-ray. Now, not everybody's going to have 1.5 miles of bone as this patient does. And if they're deficient in bone and they're missing it, I can have another conversation. I can say, look, that's the implant I want to place, but look, you don't have enough bone for it. We need to do some grafting here. And the patient's like, oh yeah, I can see that. And that's a very different conversation than just giving them an itemized shopping list where you add grafting on top of it, because they're just like, what the hell, why do I even need that? So we're kind of letting the patient co-diagnose. Now, once they agree and we work out the finances with the patient and they're ready to go, then I just take that entire file and I transfer it back into my CEREC. I design the surgical guide, and then in about 30 minutes, we mill out the surgical guide and we're ready to do guided surgery. I'm actually going to make myself just a little smaller here because I'm blocking some of the slides. And I just like pushing that button and doing that. CEREC Guide 3. That's what I'm going to typically use to design all of this. Now, CEREC Guide 3 is the latest version of guided surgery from Dentsply Sirona. It is compatible with our Axeos scanner. It's compatible with the imaging that we do with CEREC, and it's compatible with Dentsply Sirona implants, mainly Astra EV, Ankylose, or Xive. Now, if you don't use that type of implant, we can use the CEREC Guide 2. But the advantage of the CEREC Guide 3 is that I'm able to do a fully guided osteotomy and fully guided implant placement, and I don't need to use keys. I can do a keyless surgery, and that makes it really, really convenient. If I'm doing a CEREC Guide 2, then I do need to use keys, and it's only a guided osteotomy. I have to place my implant freehand. The thing that I need you to understand with this is that just because the technology is there, we need to make sure that the education is there as well. And it's not as simple as, wow, that looks super cool. And hey, this Butterman guy showed me in an hour webinar, and I think I want to just go start doing that. There are risks, there's education, there's components. And just to do a plug for CDOC, since I'm passionate about it, we can teach you all of that kind of stuff at CDOC with our implant placement and restoration courses as well. But you don't have anybody watching your back when you're planning with a CEREC guide. There are other workflows that you can use, such as CCAT digital guides and many other guided systems where somebody will help you plan it. But with this, you got to watch your own back. So you need to know that when you plan your implant, your drill might go deeper than your plan, and don't plan it too close to vital structures. So let me walk you through the actual process. And this is on an actual patient, and you can just see the steps. I do this literally live in front of the patient while they're there for their consultation. So I'm going to open my software, and the first thing I'm going to do is click on CEREC Guide Planning. I'm going to tell the software that I want implant positioning, and I also want prosthetic planning. And then I'm just going to select the tooth that we're going to be doing this for. From here, we're going to move into our acquisition phase. And the goal is, and this is something my assistant is doing, it's not something that I'm typically doing. My assistant is going to scan the edentulous space. And this is what's going to be used for planning, but it's also what's going to be used to manufacture the surgical guide. So we need a nice, clean model. The software is now going to then very quickly design a crown proposal. It's taking into account, obviously, the adjacent teeth because it has to fit in there. And it's taking into account the opposing teeth. You can see those occlusal spots. Those marks are showing where the high occlusion is. So I can very quickly understand how tall, where that restoration needs to go. I can edit it so I can make it look like it's emerging through the tissue, and we can have the proper emergence for this restoration. And I can change everything about it. Basically, what I do is I just pretend, hey, that's going to be the final crown. The implant is already in, and I'm trying to get a first look at what their crown is going to look like, because I'm going to show it to the patient, and we both need to be happy with this. If we're not, we need to figure out why are we compromising, and if we are going to make a compromise. We can close up our embrasures, any occlusal high spots, we can fix that, even though it's not technically necessary to fix that, but we can get it perfect so that we know, okay, that's going to be good. That's going to be a restoration that I'd like. From here, I'm going to take that file and I'm just going to export it. When I export it, it's going to take the crown design and it's going to allow me to bring it into my CBCT software. So I've done my Axeos scan, and for those of you that have this technology, we're going to export it as an SIXD file, which means that you get a color image when it goes out. So here's my Axeos scan. And this has now been opened into a software package called CCAT 2.0, and this is the implant module for it. So when I open the implant module, I can very quickly scan through this. And the first thing I want to do for mandibular implants, mandibular posterior implants, is I want to map the nerve. I want to know where that mandibular canal is. So I'm just going to find it on the scan, and we're just going to click through, and we'll just map all of that out. So we now have a safety zone. The software, once you map the nerve, the software now knows where it is, and it will alert you if you bring your implant too close to that nerve. You'll get a warning. You'll have a red area that shows up around your implant, and you'll know that, hey, I need to either get a shorter implant or I need to change the position of that. So it really helps you in that regard. Once you've mapped out the nerve, then it's just a simple matter of clicking on prepare, and we're going to import our optical scan. So this is my CEREC scan where I just plan the restoration, and it's very simple. I just click on the file, and once we open it, the software is going to say, okay, well, here's the crown that you just designed, and is that the one that you want to import? Here, I don't need to import the upper jaw. I'm just importing the lower jaw because it's simply a crown on tooth number 30. Now the software wants to know what are the common points, because what's about to happen is the optical scan is going to be merged with the X-ray. So I'll be able to see exactly where the gingiva is based on the optical scan. And I'll be able to see exactly where the bone is based on the X-ray. And we have that one merged object that is perfect. Once it merges, the software will just ask you to confirm it, and you just take a look and you scroll through and you say, yes, that looks accurate. The only warning with this I'll give you is that if you have a ton of metal, sometimes this can be a little bit challenging to do. With the software, though, with the Axeos scan and the ability to eliminate the metal artifacts, or at least reduce them, that is generally rarely a problem. But now you can see we've got the teeth, and the gingiva and the crown has been fused onto our reconstructed X-ray. So now I know exactly where that crown is. I know exactly where the crown is going to go. And now I can go through my catalog of implants. In this case, this was a 4.8 by 11 Astra EV implant that I selected. So we can say, okay, and we just drop it into the right spot. Now I'm just going to be using rotational tools to take that implant, and I'm just going to position it so that it lines up both in bone and it lines up properly underneath my crown. So if you want a screw retain restoration, why not just have the screw access hole coming right through the central fossa of the crown? If you, and this patient has a fair amount of bone, could I have free-handed that implant and gotten it in bone? Yes, very likely. I certainly could have done that, but would I have done it to the ability that my screw access hole was perfectly centered right through the central fossa? That's definitely something that is more challenging. Now, not only do I have the implant in the crown, I can try on the abutment, and I can at least see, do I need to raise my implant? Am I gonna have to do profiling of the bone afterwards? Because I can now see everything. I've got my implant, I've got my abutment, I've got my crown, and I can try all of that in and just really appreciate what's happening here. Again, I do this, everything that you're seeing now, I do this live in front of the patient, and we're planning this together so that we understand, is this surgery that can be done? And then also the patient, they've never seen anything like this level of treatment. They've never seen this level of diagnosis, and they're just blown away by it. Acceptance is not automatic, but it's getting close. So once I'm finished planning this, and I can see where the sleeve is going to be in my CEREC guide, once I'm finished planning this, I'm just going to take this file and I'm going to export it back into my CEREC software. And I will show you that. So now I've taken that file and I've just pulled it back into my CEREC software. Again, I'm just doing that live. I've got my CCAT implant sitting on my computer in the operatory with the patient there. I've got my prime scan in the room with us, and I literally just pull this file back and forth through my network in my office. So now the software knows here's where that implant is going to be, and we're just going to, it's just going to walk us through the planning of the surgical guide. If you've ever designed a crown in the CEREC software, planning the surgical guide is much easier, much less involved than actually making your crown, because basically it's just going to set the sleeve, and then you're going to define the seating area where you want your surgical guide to sit. Now we're limited in size by block size, and we're limited in size also by the type of mill that we're going to use to manufacture this. So you can mill a surgical guide with any of the CEREC mills that are on the market, MCX, MCXL, or Prime mill. The prime mill and the MCX are going to use the smaller, the Medi block. This is the larger Maxi block that is used for the MCXL. So what we're going to do is just kind of take that guide and we're just going to move it around and we're going to say, okay, well, how does that fit in the block? How well does that fit in the block? What are the areas that are outside of the block? And what do I need to cut away? So once I position it properly, then we're going to be in an area where I've got this designed and ready to go. So from here, if I want to create some inspection windows, I can certainly do that. The guides are relatively clear PMMA materials that we're going to manufacture, but still it's nice to verify that they seat properly. And you can do that just by creating some inspection windows so that you can verify that this is down all the way. The software is automatically blocking out undercuts. So this will be a nice passive fit when you go to seat this in the patient. And once we have it designed, then we're just going to go to the manufacture phase and you'll be able to see what the block looks like. This is it. And it will just mill this out. This one probably takes 35 minutes. It's a little bit faster with the prime mill and the slightly smaller block. But generally, you saw how long it took to do the planning. How are we in our webinar? We're about 30 minutes into it, and I've done a lot of other talking. When I do that live in front of the patient with no talking, it's the entire design process and the milling of the guide is somewhere around 45 minutes. So you can do same-day guided surgery if you want. I don't often do same-day guided surgery because we have to deal with schedules and financing, but you absolutely can, which is nice. So we've got our design guide, and now we're going to set up that block and we're going to manufacture the CEREC Guide 3. So the guide itself is manufactured, but what we want to do is keyless surgery. So when I'm using a CEREC Guide 3, I'm generally going to be doing an Astra EV implant with it because that's compatible with that. So I'm going to use my guided surgical kit in order to do that. You'll notice the hole in there, we've got one size hole, so we need to have the ability to shrink the diameter of that hole. So we're going to, after we're done milling it, we're going to get a sleeve. So with the Astra EV system, for example, and this could be on a couple different implant types, but the Astra EV system, this would be a wide diameter sleeve because it's a 4.8 implant. So I just bond that into place, or a narrow diameter sleeve for a smaller implant. And that's just going to be bonded into place with cement. So let's do a little surgery. This was that case that I just planned. This is the case that I just designed. And I sped this up. Don't worry. You won't have to sit through a long surgery. And I wish I was this fast, but let me just kind of run it through. Our patient is numbed up. My first step, we've got more than 3 millimeters of remaining keratinized tissue. So I typically will do a punch in that situation. If I don't have enough keratinized tissue, then I would do a flap. But in this case, we're going to have plenty of keratinized tissue. So we do our punch through the guide. This is the initial drill. So it's going to remove a little bit of the cortical bone, and it's going to remove any remaining tissue around that punch and just get the site ready for the osteotomy. Now we're going to do drill number 1. And you'll be able to see as these drills come in, there is a sleeve attached to it. And that's what's shrinking the diameter of that hole. And I'm just making my way through the osteotomy. Drill 1, drill 3, and I'm just irrigating and cleaning out the osteotomy as we're going through. And then we'll come in with drill 5. And this will end the basic part of our osteotomy. And now I'm going to come back and widen the cortical bone. With this system, you can really fine tune the bone and have the torque exactly the way you want. So I'm just removing a little cortical bone, and her bone was relatively dense. So I'm using an optional drill just to remove widen the apical third just a bit. So now our implant is there. We're placing our implant guided through the guide, and there is a vertical stop line that I'm watching so that I end up in the right position. So how many check films do I take during the surgery? Well, I don't take any check films during the surgery because I'm doing this guided and I've already planned everything. The implant can really only end up in one place if I've been accurate along the way. And really that's the benefit of having a really good Axeos scan, because now you have an image that is going to be very accurate. So my patient then leaves with a healing abutment. How long does a surgery like this take? If I showed you this video in real time, which I have, the entire surgery from anesthetic until she gets up to leave the office is 20 minutes. and how much stress is involved in that? Well, really none, because I already know how this is going to go. I've already done the surgery digitally. So now the patient the implant is in, and one of the things I love to do, we've all done this with 2D films, and you take an X-ray and everything looks just great, but how do you really appreciate where it is buccolingual? And I think that's where we get into a lot of trouble with implants. We sometimes don't understand that maybe the implant got a little bit too close to the buccal plate, and if we're starting to lose bone, then how do we deal with that? And really, how could we have prevented that? So one of the things I like to do, and I mentioned earlier, whenever I do a root canal, whenever I place an implant, I just don't take a 2D image anymore, because an Axeos low-dose scan, it's got about the same amount of radiation as a 2D image, and it gives me much more information. I can see stuff like this. So how do I restore it? Implant's been placed. We've already done this fantastic digital workthrough to get the implant, the prosthetic planning of the implant, all the way through to the surgical planning, and then the execution of it surgically. Well, how do we have a situation now where we're going to maintain and keep that digital workflow, and we're going to be able to restore it? So obviously there's no questions that are coming through, because this is just so well explained to you guys, and you're getting it, or it's just like, I don't know. But by all means, feel free to jump in with questions at any point, and we can talk about anything as we're doing this. I'll finish early for sure and respect your time tonight. So we'll be able to talk about that as well at the end. But there are multiple ways to restore implants with CEREC. One of them is using a tie base. I won't be speaking about that tonight, but the premise behind that is you're going to purchase a titanium base specific to your brand of implant. You're going to scan that with a scan body in the patient's mouth, and then you're going to design out either an abutment or a screw retain restoration that you then bond to that tie base and bring to the patient's mouth. The workflow that I'm doing probably 80% of the time at least, though, is an Atlantis workflow. And quite simply because it's easier and it costs about the same, but it's just much easier. So if you've never ordered an Atlantis abutment, they're pretty insanely good. The contours are fantastic, and the anatomy is there. First question: do you routinely charge 3D scan for implant placement? Yeah, really good question. In my office, a full series of X-rays is going to be a 3D scan and 4 bite wings. I know there are offices that are getting a full fee for a 3D image for it. For me, I would give this stuff away all day long just because of the treatment that I get on top of it. I don't want it to be a roadblock. When I'm just starting to evaluate for implant placement, I don't want it to be a roadblock. So I'll typically charge my normal full series fee or a Panorex fee when I'm doing a cone beam X-ray. And if I have to, it's the first thing I give away because I just want to know, and I need it. I don't want a patient to say, hey, yeah, well, I don't want to do a cone beam scan. I don't want to pay for that, and let's do your implant. So anytime you add a price to something, then you have to talk to the patient about it. And I don't love talking to my patients about money in the first place. But once you do that, it gives the patient an opportunity to say, well, I don't want this and I want that. I want to be the one that decides. So if I need to, I don't charge for it. But great question. So in Atlantis, the premise behind the Atlantis workflow, if you haven't done it before, the premise behind this is I'm going to do a scan, and I'll show it to you how it works in just a minute. I'm going to do a scan, and I'm going to send that through my CEREC to Atlantis. Atlantis is going to create the abutment portion based on my feedback. I'll be able to approve it or make changes to it. And then they're going to send me a core file in order for me to make a crown. Now, basically what a core file means is before the abutment has actually ever been made, they're going to send me a virtual abutment that is attached to the model, and I can pull it into my CEREC software, and then I can design and manufacture the crown on my own. So it costs a little over $200 for the abutment, right around $200 for it. And then the cost for the block for me to mill my crown. So it's probably like $250 all in with this kind of stuff. So the cool thing, that thing that blows me away, is I'll actually mill and make my crown before Atlantis has ever made the abutment. It takes 48 hours for it to show up in your office, but you make the crown in advance, and then you put the crown on the abutment. It's like, oh my God, it like fits perfect. So it's insane how well these fit, and it's cool that you can do that off of a virtual file. So in order to image, and some of you are taking, I'm sure, analog. I'm sure a lot of you are taking analog impressions. The principle is exactly the same. When you do an analog impression for an implant, you're going to take an impression coping and you'll attach it to your implant, either an open or a closed tray. You do your physical impression and you send that to the lab and they pour it up. Here, we're also putting an impression coping on. This just happens to be a scan body. And it's going to have orientation notches on it, much like an analog one does. But now the lab is going to, or Atlantis is going to be able to take those orientation notches and line it up in the software, so the software knows where in space your implant is. So we use an IO flow for these scans. So this is the same patient I did surgery on, and now the patient is returning to scan for the restoration after healing. I generally go with an Astra EV implant. I'm generally about 8 to 10 weeks out for that. So we're now going to set this up in the software, and I'm going to take the software, and I'm going to actually use the Connect version of the software, because I'm not actually designing my restoration at this point. I'm now going to be sending this off to Atlantis for them to create the abutment. So we're using the Connect version of the software. I'm going to say what type of implant. Sorry, I know the words are a little bit tough to read on this. Resolution's a little bit low, but I'm just going to select that as a Dentsply Sirona Astra EV 4.8 implant, and here's the scan body I put on. So I'm just going to tell the software what's the implant, what am I putting on here, and then we're going to get our scans. So when it comes to our scans, I'm going to need a couple of them. I need to have, and I'll let it go through and I'll just walk you through the imaging. And again, this is in real time. I sped up just a teeny bit for the scan body, but I just want you to see in real time how it looks to scan and how difficult it is to scan. So first thing we're going to do is we're going to take off the healing abutment, and we're just going to scan the tissue where the healing abutment was. So this is it, because we're doing number 30. This is her lower jaw scan, and I'm just going to scan and I'm going to fill all of that in. It doesn't take very long. We're just going to isolate a little bit. I'm capturing the adjacent teeth. I'm capturing all the data that I need. And I do this without the healing abutment because I want to see the contours of the tissue. I want to see what the tissue looks like so that we can make sure we capture and get the contours of the abutment properly. Now we're going to do the opposing arch, and we'll just quickly fill that in. And once we're done with our opposing arch, we will move in and do our buccal bite. So we just want to know how the upper jaw and the lower jaw are going to articulate. So we have our patient closed down. That's my assistant Bree next to me, my literally right hand. And we can fill all of that in. And then finally, for those of you doing analog, this is where you would put your analog impression coping in. Because we're doing it digitally, now I'm going to take that IO flow, and we're just going to attach that and screw it into the implant in exactly the same way that you guys would do analog. Once we attach it, we're just going to scan that. That flat surface that you see towards the lingual is the critical area. That's what we need to fill in here. So we'll just fill that in. Here I've just sped it up just a little bit to save some time, just to kind of capture that image, but you'll get the idea. And all I'm trying to do is capture where that flat surface is and enough common data so that my lower jaw scan without the scan post merges with my scan with it. And all of this is going to be packed up in the CEREC Connect software, and I just submit the case. So when I submit the case to Atlantis, about 10 minutes after I hit submit, they're going to have it. And so now they're going to allow me to put some information. I can start talking about what kind of emergence do I want? Do I want to put pressure on the tissue? What do I want my margin height? If we're doing a custom abutment, it'd be nice to say exactly where we want our margins. So if we are going to cement this, then we don't have to worry about cement cleanup because we placed our margins in the right spot. We can choose exactly how much pressure to put on the tissue. So when your patient comes back to deliver your restoration, and they say, "Hey doc, are you going to have to numb me for this?" What do you say? Well, I don't know. How much pain can you take? Because sometimes it was a lot of pressure and sometimes you do. I get to choose my emergence. I get to know exactly how much pressure is going to be on the tissue, so I know the answer to that. Contour tissue is going to put up to 1 millimeter of pressure on the tissue, And generally patients are going to tolerate that quite well. There's a lot of research coming out about the shape of the abutment. And it's not random. We need to make sure that we're paying attention to the shape of our abutments, because what we're finding is that if we have an emergence of the abutment off of the implant that's greater than 30 degrees, or think of it this way, if your abutment is convex in shape coming off of your implant as opposed to concave, there is a very high degree, over 37% degree of peri-implantitis around those. So we really want to pay close attention to the emergence of our abutments. Once I submit my order fully, and this is just a different case that I'm opening just to show as an example, they're going to allow me to go into an editor and I can take a look. And they're going to say, okay, here is our plan. What do you think? There's just a virtual crown that's been placed, and I'm going to be able to look at this abutment in every dimension. I'll be able to scroll through and take a look and see. I can take the tissue and I can make it a little bit translucent, and I'll have an idea, where is that margin? Now, if I like it, I can approve it. If I don't like it, I can either ask Atlantis to change it, or I can use some tools and just move the margin around myself, whatever I like. Once I'm happy with it, I'm just going to hit submit. These are the tools that I can use, and I can literally pull those margins anywhere I like. I can raise or lower the actual abutment, change any of the contours with it. Once that's done and I submit it, about 24 hours later, or sometimes less, I'm going to have a core file that's ready. So that's that virtual abutment. Even though it hasn't been manufactured, I can still download the file. So here's what it looks like in the software. So Atlantis has sent me the core file. The restoration, the abutment hasn't even shown up in my office yet, but I'm still able to pretend as if I've actually placed it in my patient and taken an impression of it. So it's virtually been placed in my patient. And all I'm going to do is now treat it as a tube. This is the abutment that's going to be shipped. It even comes with a margin already drawn on it. I don't have to mess with drawing a margin. And then it's just a crown design. All the steps that I normally do, and if you haven't seen a crown design on CEREC, you can just see how quick it is. This is the initial proposal that comes out. I can start changing and adjusting my occlusion so that it's perfect. If we get it up too high, with the click of a button, we can raise it or lower it so that it's exactly right. If we want to close some of the embrasures and get our contours adjusted, we can certainly just grab those areas and pull and close any of those embrasures so that the patient's not going to catch food. And this is based off of my initial, and I already know what this crown is going to look like because I planned it before surgery. I had a really good idea of the kind of restoration and what it was going to be because I looked at it beforehand. We can adjust our contacts so those aren't too heavy and that everything is touching just right. And then if I'm doing a cemented restoration, I'm done. I'm just going to mill it. In this case, I wanted to do a screw retained restoration. So the software, if you get this file back from Atlantis, you'll be able to see where that abutment was, where the screw access hole in the abutment is supposed to be. And then you can just use tools to create and to dimple that. Let me just fast forward here just to save time. I'm just going to create that dimple in the software, and then we're going to send it to the manufacture phase, and we'll mill out this restoration, and it's going to have a dimple in it. Normally, it'll actually have a hole in it as well. Now, I do need to come back manually, and you'll see what it looks like here. I do need to come back manually and just take a burr, and this is zirconia for those of you that haven't worked with it. And it just in the green state is soft like chalk, and I'm just going to punch through that hole and get that opened up. And then directly behind me is the abutment that Atlantis made, and that comes again 48 hours later. I make the crown that comes on top of it, and then I'm just going to extraorally bond the crown to the abutment, and you can see our screw access hole ready to go. And then I can just deliver that entire complex to the patient, and we can get a good result. Cost-wise of this, well, the guide that I used, that I milled, cost $55 for the block. So why not do guided surgery? It's $55. My restoration for the Atlantis custom abutment and my crown was about $250. So for guided surgery, I'm all in with the guide and the restoration for $300. So why wouldn't I do it every time? Just very briefly, another case in an anterior where we can plan these out. But the main thing I wanted to show you for anterior cases, I really get concerned when I just see a PA like that and the dentist is secure and thinks, okay, everything went great. Everything looks good. The implant is exactly in the right spot. How do you know? Again, if you have a problem on an anterior case and you end up with an aesthetic problem, the very first thing that's going to happen is somebody's going to take a three-dimensional x-ray. And I want to know if I take place an implant, I want to do that low-dose scan so that at time of surgery, I can take a look at my plan position. And what you're looking at now is a different system. It's an Axeos scan and it's CEREC scans, but I used a system called a Zento to plan and map this case. But we can see our pre-op and we can see our post-op, and we can know, yes, there's a buccal plate. My implant was positioned correctly at the time of surgery, and at least on day one, we know that we've done everything right, and it really can cover your butt. And you know that legally and medically, you've got everything's been done right here. So I much prefer to take a 3D image, a low-dose image, when I place an implant instead of a 2D one. And then again, the level of care that you can get with this, I just briefly mentioned the Zento, and I won't have time in this webinar to go into detail, but it's the same idea. You're going to do guided surgery, but they will actually give you pre-manufactured temporaries, and so you can place these temporaries at time of surgery. But I'll just end on this case where when the site heals, the principle is the same. If I need to scan, we've got our healed site, patient was wearing a temporary. I can now take my IO flow, place it in, and we'll be able to send this to Atlantis. Atlantis is going to give me a visual of where the crown's going to go, where the abutment is. I can change the margins. I can alter it. If I want to do screw retained or cemented, we can work all of that out. And then they send me the core file, and I just design a crown. Even though it's an implant, it kind of takes all the pressure off because Atlantis has designed the proper contours of the abutment. I'm just designing a crown. So we can have our Atlantis abutment that's fabricated and our final restoration that comes on top. And this level of aesthetic treatment, this is not expensive to do. This is very, very predictable, but it's only predictable if we plan everything. We plan everything prosthetically, if we plan everything surgically, and there's no excuse nowadays. Nowadays, with the technology that I've talked about, simply using an Axeos scan and doing a prime scan for optical scan, you know where it's going to end up. There is no mystery here. There are no surprises because of this. So there's really no excuse that I was trying to figure out, and we had to make compromises. So I would encourage you guys to take a look at this, and we'll just in the last couple minutes, if there are any questions, we can jump in. I would encourage you guys to reach out to Schein, reach out to your reps, just take a look at it, take a look at the technology, because it's there now, and this is not the future. This is what's happening in dental practices around the globe, and it's just predictable, and more importantly, well, not more importantly, but just as importantly, it's fun. I love doing this kind of stuff, and it takes the pressure off. It makes it exciting. What questions? Anything that we have? I see blank screens on the question and answer. I saw one question on the chat. So either you've all fallen asleep with all of this, or it was just overwhelming, or it was just totally clear. I'm not quite sure exactly. Oh, here we go. D1 student. Oh, my son is a D1 student. Congratulations on dental school. That's awesome. What are you using to manufacture the guide, and have you found any limitations using all digital model? So the guide is being made out of a PMMA acrylic material. So it's a block, it's just an acrylic block, and it will actually be milled in a CEREC milling machine. We do have an option through some slight variations in the workflow to also 3D print that if you prefer. What are the limitations of a digital model? I would say there are only positives. There are limitations in physical models as far as I'm concerned, because the accuracy of the physical model is dependent on the impression you took and how you poured it up. If I want a physical model, I just 3D print my digital impression. So in my office, this is going to sound stupid, but probably when you graduate from dental school, well, certainly if you come to my office, we don't own stone. I don't have alginate. I have some old expired polyvinyl impression material that I can't remember the last time we used. It's just not a thing anymore. There's just not a reason. I won't say physical impressions are dead, but they're kind of dead. Any other questions?
I think your presentation was so well put that nobody has any additional questions.
I'm going going with that, Adam.
Oh, we may have gotten, let's see. What training do you recommend if you want to learn how to do all of whatever you just explained?
Yeah, I don't want to mislead you guys because it does look easy and it can be easy, but you do have to have some advanced training. And there are multiple centers to learn this. But again, I am a little bit biased, but I'm just because I'm biased doesn't make me wrong. I think the best education out there is through CDocs. And we've got some of the top periodontists and oral surgeons and GPs as well that are teaching this stuff that will get you to where you need to be using the digital technology. So if you invest in this kind of technology, it's critical that you learn how to use it properly so that it's not just sitting collecting dust. And I would encourage you, if you haven't, take a look at the CDocs website and just take a look at some of the offerings that we have, because you can learn how to do all of that. And again, there are many other sources as well, but that one I know the quality is there.
Perfect. Well, I am not seeing anything else, so I think we'll end a little early this evening. So thank you, Dr. Butterman, for the great presentation. And of course, thank you to Dentsply Sirona for sponsoring this webinar. If anyone does have additional questions about the Axeos and or adding it to your practice, please feel free to email us at webinars@henryschein.com, or you can email Dr. Butterman directly. Additionally, if anyone is interested in attending future Henry Schein webinars, visit henryscheindental.com/webinars for our upcoming schedule. This webinar was recorded, so everyone will receive it sometime in the next week. Thank you all for joining us and have a great night.
Thank you.